by a dentist, you can be owned by a mutual community or BUPA or one of those health funds. The practice can be totally outside your jurisdiction, but at the end of the day, the person working on the patient is responsible for the infection control of that practice. And if you don't like it, you've got two options. You either leave it or you change it. And my most important thing, professional judgment. With dental profession, we understand what we do. Everyone else thinks dentistry is rocket science. It's not. It's just good oral health care. But the professional judgment has to come from within our profession. All right? You can't take things over the top. Otherwise, we're going to get no patients treated whatsoever. You can't make a whole lot of rules without understanding why you've made the rules. You've got to know. If you want people to wear gowns, you've got to know why. And you've got to know, if you want people to wear masks, you've got to know exactly how you want them to wear them and when you want them to wear them and where you want them to wear them. This is the basic rule of infection control. I'm not going to read that out. You can read it later if you wish. It just basically says that we're not going to infect patients ourselves or any other person that may come into the periphery of our occupation. Okay. We understand the principles of infection control. Some of these documents we've tried to make them more readable because the original ones were pretty hard going. The part I like is knowing about specific infectious diseases and how to take precautions against them. I think that's what infection control is about. It's like I take you back to how I treated the first person with HIV who came to my practice, and I said, I can't treat you. Now, I should have been able to. You know, there's no excuse for not having done some research on HIV, even if that was, you know, probably only about the second or third person in Australia that we'd even heard that had it. It should have been something I should have said, I'll come back tomorrow, I'll see what I've got to do. Anyway, I learnt over the years that that's how you approach it, but a bit late now. All dental staff need appropriate training. You're here tonight, congratulations. And compliance with procedures is much more likely if everyone works as a team. And I know that a lot of people have come here tonight as teams, and that's super, super critical. This is what the duty of care that you have, which I've been talking about, and it gets further than just a duty of care. There's actually legal requirements on you to follow some of these guidelines and to have them in place and to make sure that your staff is protected. You must develop and implement work practices to ensure compliance with infection control standards. Now, you've got the standards. They're not over the top. Where things say should, that means it's optional. Now, I'm not telling you that you all go away and say, it says should, so we're not going to do it anymore. But there are some practices where some of these things that are written just do not apply, and that's, you've got to be your professional judgment. Where it says must, that's a must. And if you want to go against a must, you're going to have to be able to validate that scientifically. Implement a hand hygiene program. The hand hygiene has been the super duper new thing since 2010. I have been screaming from the rooftops since about 2002 that we had to move to an alcohol rub. It got taken up in the Adelaide Dental Hospital, for which I was very grateful, and our incidence of hand issues went down correspondingly. The level of dermatitis went screaming down. But more than anything, our compliance with hand hygiene went up. So I can speak from absolute clinical trials, from personally living it, that hand decontamination works, whereas routine hand washing between and after every patient, it doesn't work. People get sloppy, they don't want to do it, their hands break, etc. So or the skin breaks, not the hand. It'd be a bit sad if the hands break. And obviously implement systems for safe handling of sharps. This means that if the sharps container is nearly full, you get rid of it. You don't jam a few more sharps into it because you can't take it off the wall, all right? Because the cost of a stick injury will far outweigh the cost of a few more sharps containers. By the time you do counselling, testing, the sheer stress of having been stuck. Now, I've been stuck, usually when I stick myself, I try and do it with more than one virus because it's more entertaining. But I've been stuck about 7 times. And I must admit that when you know enough about infection control and you know enough about the viruses, you do get a little bit blasé about it, and I can't say that I've lost any sleep about it. But that's not the case for someone who doesn't live, eat and breathe these germs every single day of the pathogens every single day of the week, bar Saturday and Sunday. And you have to remember that for most of our staff, when they get stuck, it's like I was back in 1983 when the guy comes to the door and says, I have HIV, and I think, oh, that's how our staff feel if they get stuck. All right? And no rationalisation in the world makes them feel better until they get that test back that says, no, everything's okay. Even though we can say 99% certain, you're going to be fine. But it's the 1% that they will think about. And that's what costs you. So don't muck around with sharps containers. There are reasons for all the regulations these days and the guidelines. There are scientific sound reasons for them. You have a duty of care to implement systems to ensure a staff immunisation program is in place. Now, this is important. And I'll harp on about immunisation for influenza a little bit later. And also everyone has a duty of care to be aware of their blood-borne virus status. Now that doesn't actually mean you have to go and get tested every year. You might want to go and get tested, particularly if you have an insurance policy that asks you to get tested every year. But there's 2 ways you can sort of get infected. You can get infected occupationally through a stick injury. It has not happened in Australia, to my knowledge, in dentistry. All right, it certainly hasn't been documented as having happened. The other way you can get it is in your social life. Now, providing you haven't been stuck, and providing you haven't sort of decided to have relations with about 5 or 6 different people with unsafe sex, then basically your immune status is unlikely to have changed for a blood-borne virus. But if socially you are having a pretty good time and or if you stick yourself, then you're going to have to get checked accordingly, all right? It would be probably a good 12 months or so. We had a stick in the clinic and I decided to took the person up and got myself checked at the same time. I think it's a good over 3 years before I had an incident, and there's no reason my immune status should have changed. But I usually get myself checked purely and simply because I treat personally about 400 people with HIV a year. And I can stand up and say, hey, this is easy. It's not hard. It's not rocket science. Okay. Now, the immunisation that you should be looking at for your staff: hepatitis B, varicella, measles, mumps, rubella, pertussis. That's an important one. We've had 2 people in our clinic in the past 12 months who have come down with pertussis. So particularly if you've got up to the 40-plus age group, you should think about getting revaccinated, all right? It's okay if you're a bit younger, like that mob up there. You're probably not at risk, but for the older people, if you haven't been revaccinated for pertussis, Bob, you should do it. Okay, and you can refuse to be vaccinated, but we're going to want you to sign in blood why you don't want to be vaccinated, and then hopefully that's going to save us, particularly as an institution, most certainly as private practice, from any repercussions if you will not undergo vaccination. It is your right not to be vaccinated. Having seen what happens to people with influenza, I think it's a somewhat silly course of action to take. That's my personal opinion. I think vaccination is great, and I'll finish this lecture with why. So, it's all 24 years since the ACER case, so some of you, aren't even that old yet, probably. And we were still learning about disease transmission as quickly as we could. Now we understand it's no more hocus pocus. We shouldn't practice infection control just because someone says you have to do it this way. There should be a reason for it, all right? We're beyond just doing things because it sounds like a good idea. It either is a good idea or it isn't a good idea. The Australian Commission on Quality, Safety and Healthcare, ASQA, looked like looming on the dental horizon as being, sort of not so pleasant organisation to deal with. They were coming up with a whole lot of tools. They were going to audit dental practices. My inside information is currently that might be on hold.